Thank you. So we'll convene the Prescription Drug Affordability Board. It's 10 o'clock. Introductions. My name is Gary Merchant, Representative Gary Merchant, Chair of the board.
Todd Fahey. Bob Woodward.
And to establish a quorum, I will elevate Bob Woodward, Dr. Woodward, to a full member for this session.
Thank you.
You're welcome. That will establish a quorum. And as far as the agenda, is there any questions on the agenda, things that people want to add, delete, move? All set. Continue with the agenda. Approve and review the August 22nd minutes.
Motion to approve.
Second. First one. Second.
I'm gonna abstain.
Okay, did you want to-
Yeah, I wasn't here. Yes.
Minutes approved. Thank you, sir. Senator. Okay, and this, it's not Zeno, it's
Radme.
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 Ms. Radme, you want to come forward and update us on the board rules and the journey we're on? And
Sure. All right. So on Monday afternoon, the 19th, we received comments back on our initial proposal from OLS, their staff attorney. We had quite a few comments, a lot of them in the 200s and 300s, and the 100s, I think maybe a couple editorial things, nothing major. We need some work, or we have some work to do. Most of them are legislative intent and unclears, a few authority comments, which means they are all grounds for objection in front of the committee. And the committee is very objection happy lately. So we do want to move forward with these rules as buttoned up as possible. With that said, because they've been postponing things a lot. So they have a continued meeting on October 6th. They scheduled this for that date. I'm still asking them to postpone to the October 21st. With hopes of, and correct me if I'm wrong, a representative, that maybe we can convene an additional board meeting before the 14th of October. That way we can work on these comments and get a conditional approval request approved and filed by October 14th for the October 21st meeting.
We can't do that yet.
there's three of us, so as long as there's three here for the board. For a quorum.
Right.
We can do that
Right. I'd rather do it today
today.
than have another meeting.
We can try.
The only thing is, we're in a catch-22 because we received them back from
We have
OS. We haven't had a chance to look at it. We haven't had a chance to
Yeah.
vote in public, but that's
I
kind of.
may have trouble making second meetings, but I'll try.
So we have to notice it on the House calendar, Senate calendar, which goes out on Wednesday, which would be the 28th. That will be out on the 29th. So the earliest we could do that is going to be probably, it's going to be tight.
And I know we had spoken to get them published on your website by the 6th,
Yes.
so we can file for the 14th. So the board meeting being the day before we file.
We have to announce the board meeting unfortunately 2 weeks before.
Mhm.
So we do it. We can't do the 6th. Because that won't give us time. The 2 week notice is going to be problematic. If we did it today, we could do it. Well, we don't have to publish it per se,
Yours has, the draft we come up with needs to be published a week before your meeting.
right? But the notice of the meeting has to be published 2 weeks before. But no,
Which is-
but it doesn't require it to be posted. We could post it on the website and
Can we meet on Columbus Day?
Yeah.
There's no, it's a holiday. I don't know. Is it a state holiday?
I don't believe it's a state holiday.
Okay, let's do
so
it
if we do it now, we could actually announce it today on the board website.
Okay,
There's no requirement for it to be posted in a particular place.
okay,
Just has to be noticed.
Okay.
We have done historically in the house calendar,
Mhm.
but we can post it publicly on the board website
Perfect.
and then and post it within the HHS as another place to go. Bulletin board, so we put it publicly within the department. You have a bulletin board out here, we can put it on.
A physical bulletin board
Yeah, what do you publish things for DHHS when you do
Uh,
meetings?
on our website, on the PDA page.
You do it any place else?
No.
What about other meetings that you have is within the department?
So my rule meetings, I post in the rulemaking register for OLS and I post publicly on my ARU webpage.
So when you
Under
go
my
on
public
to
hearings.
where does it go? What does that get noticed?
The ARU webpage, I can post, I can notice it today. The rulemaking register. If I tell them today, it would be a week from this week. However, I don't know if they would necessarily post that on their webpage.
When do we need to meet by? The 14th,
Yes,
so can everybody do the 10th?
I can.
That's a Monday.
Yeah,
Monday.
Todd,
Yes.
Bill, can you do the 10th?
Yes, I can talk.
No. It's not a state holiday.
Justin. I'm looking for the requirement for posting the meeting.
I think 10 o'clock.
10 o'clock.
You want to meet at 9,
Nice one. You want design work?
9 to 11? Is that too early? I just saw that and gasped. 9 work for
On a
everybody?
Monday morning, 9 o'clock, sure. Each public meeting shall be announced 2 weeks in advance. The materials and meetings will be made at least 1 week, so we can announce them on the board website. That
Perfect.
complies with it.
And then we'll work and publish a draft on the 3rd. Or by the
Correct.
3rd. Okay,
So we're going to post it today,
so we have a week to work on.
So it's tentatively 9 to 11, right?
9 to 11. All right.
We could do 7 to 9.
Not all of
Just get it done.
them.
Only have to be out of Rye at 6.
That's all. Okay. So 9 to 11 on
October 10th.
October 10th.
And with that said, I do want to point out that because you guys are a board, it's a little bit harder in the rulemaking process because you have to vote on all the drafts that we put forward. So I do want to just warn you, once we file the conditional approval request, we may have additional comments. So this may end up being pushed out to November. Because unless you have a quorum to vote, you cannot at the board meeting, at the JLCAR meeting, verbally make any amendments. You'll have to bring it back to your next meeting and we'll have to refile another draft.
It would be weird to have a quorum at the jail.
Exactly, and normally that's what happens.
I mean, would we do
So-
that? Has
No,
anybody ever done that?
no, we
Oh,
wouldn't.
We're gonna go have a meeting now. We could have a
No, we
tandem
wouldn't.
meeting at the same time as jail car.
So typically what OPLC does, because they deal with this all the time, they leave the meeting with those comments, or the concerns that they know they need to continue to address, and they'll come back the following month
Oh,
to get it approved. So this may not
so
be
just to
officially
be,
approved by November,
right.
or until November.
Yikes.
Yeah, it's gonna be.
Well, the good news is that no matter what, we're all still part of the board, at least for now.
Exactly.
Right. It's not legislative.
No. Regardless of elections. So it's still on board for the 10th. We got,
Yep,
Nancy, we can post it on the board website today.
Yep.
Thank you. And then I'll circle back with you and start doing some
we'll start going
work
through
to
some.
do it.
Yep,
Okay, you got it.
perfect. Unless anyone has any questions? That's it. for me.
Do we have time, Mr. Chairman, just for just a little bit of an overview of what the objection is?
She can verbally tell.
Verbally, because these were
Okay.
very, These were very pared down rules to begin with, so.
So when it comes to rulemaking, one, this is not uncommon on your first go around with brand new set of rules. They can take quite some time to come up to par with the standards for OLS. And so, I mean, again, we're trying to fast track this a little bit before the end of this year. So we're just kind of, we're moving through rather quickly than what you would typically do in rulemaking like this. And there were some things we left kind of vague to see what comments we might get to be able to button those up a little bit more.
Okay.
And that's really what it is. There are definitely some legislative intent and authority comments that Rob will need to look at. But really, it's they want more substance within a lot of the rule text, which we're trying to kind of keep it clean and as tight as possible, but where it's a new board set of rules, again, they kind of want that meat in there right now.
So we clearly have the authority with the enabling legislation to pass rules. And is it common, in your opinion, for them to delve into legislative intent?
100% all the time. That's
Even for
yes, that's OLS's job.
the
Yeah.
simplest rules that we've drafted,
Yep.
because these are about as bare as one can find.
And that's the problem. They're a little bare. They want them more beefed up and they want things more clear.
Okay,
But legislative intent and authority is not uncommon for them. That's what they're there for.
so it would seem to me then, if we're going to go to the next phase of this and have more robust rules, then the legislative intent issue is going to be even more.
Not
in the
necessarily, because they
spotlight, right?
have their comments on here.
Okay.
That we'll know how to respond to them. And after looking at them, I don't think we can't respond to them. I just think we have to work on the rules a little bit.
Okay.
But all those comments are very much objectionable and the committee will object.
It's actually a safeguard by having gel car. Good example was in the state of North Carolina. The dental board made some rules that were impinging upon fair trade practice. And because it didn't go through a second review of the legislative body, it was struck down by the Supreme Court of the state. And it eventually went to the Supreme Court of the United States. Because of that, there's not a legislative body overseeing administrative rules. In that case, the court said you ran afoul. So even though it's hard for us,
Yeah.
it's one of those things, in a lot of ways, it's helpful.
No, certainly honoring the process. It's just, I feel that the more we delve into the murkiness of a legislative intent in our rulemaking, it just seems to me that we'll see how it goes, I suppose, right? So if this is what they're looking for,
I'm
then
very confident that we'll be able to
you are.
address. Yeah,
That's great.
I've been dealing with this for about 5 years, so very
Perfect.
confident.
Thank you.
Quick question.
Yeah.
So, we're gonna be dealing with this on the 10th.
Yes.
You're gonna send out what those comments are for us to look at ahead of time.
Yes. They'll go to the board to be, what we'll do at this point in time is we will post to the board. Notice today, we'll get the revisions, if you will, that I work on with Allison. We'll get that draft to you by next Monday.
Oh,
So the
great.
board will have a chance to also the public to see the revisions that we're proposing.
Great. Yep, thank you. Kind of a newbie over here.
And then hopefully we'll get to gel card in time for their meeting on October,
October
just
21st,
before
yeah.
the fiscal.
So my hopes for them is that they'll turn it around, so we know going into the October 21st Delcar meeting, if there are any additional comments left. They used to do that once upon a time, not so much at this point, because of how backlog they continue to be. So if we needed to, I guess, too, and that's something else that we can discuss. If we receive any additional comments prior to the October 21st meeting, where you can't address them verbally at the meeting, at that point would be request to postpone to November, because we'd have to work on them.
Is there any possibility for the board to vote to let the chair modify the rules?
You would have to talk to Rob, but I don't ever see OPLC doing that. They typically will go back to their next board meeting So I don't know if that's statewide or just a specific process.
And I'll consult with the agency's office on that.
Yeah, because in a lot of ways, it's kind of like you have an agency. The commissioner is the one sort of signing off on the revisions. Because the same thing could happen with the board here, with the chair signing off on the revisions on behalf of the board, as long as the board is giving them the authority to do that.
Yeah, I'll check with the agency's office on that.
Okay. Well, thank you.
You're very welcome.
Thank you.
Thank you.
Rob, you're up next.
This is the executive director, right, Mr.
Yes.
Chair? And for the record, Rob Berry with the HHS. Mr. Chair, I've revised the questionnaire for human resources regarding the position. Essentially, with an unclassified position, what they do is that you have to fill out a questionnaire that outlines the duties of the position, and you have to indicate how often they're going to be performing those duties, and what percentage of their work it's going to entail. So utilizing the information you provided last time, Mr. Chair, the Hague Group protocols and procedures, I've modified my initial draft slightly. I was hoping to get it to you last week. Unfortunately, I didn't get a chance to do that, but I'll send it to you after this meeting. And if it's suitable to you, we can move it along to HR and get it in the pipeline for going through the Corn Ferry Hay Group process and DAS process. And hopefully, I think it does take about 6 months, I've heard. But hopefully we can get that filed this week.
It would be nice if it was less than 6 months.
Oh, I can do what I can to pull strings, but I don't know if I have that kind of clout with DAS.
Is that who needs to sign up on the process?
So it would go to DAS first, yes, the administrative services, yep, and then it goes to the Hay Group, then JCEC, and then it goes back. So JCEC would ratify the recommendations of the Hay Group. And then it goes back to the DAS commissioner to say yes, and then it comes back to us. So it's kind of goes up and down the ladder, yeah,
After that's done, then we can actually post for the,
correct. But I'll get you the revisions I made today.
is there a possibility of hiring somebody as an interim?
We have to find a position for that. I don't know, we'd have to find it through a classified position that's vacant.
To hire a consultant?
That's potential. We'd have to talk to contracts about that, because that'd be a contractual relationship, I think. So I can follow up with contracts about that. And that's what I have as far as that goes.
And also, we talked about the prescription drug reports, if you could hold off on that one.
Sure.
They got order assessment fees. The other thing we talked about was the assessment fees we have in the statute a floor. We don't have a ceiling.
So I spoke with the CFO here. He's of the opinion that we really do need to have the rules in place before we can start collecting the assessment fees. He's been following up with me before every fiscal committee about where we are at the rules process, so he's very aware of it and in tune with it. The CFO here is Nathan White, and usually the Monday before fiscal, he sends me an email asking me where we're at with the rules. So he's very much aware of this and wants to get it moved along, but he doesn't think we can collect assessment fees until we have that in place.
All right. And Dr. Woodward, you have a report you created, so I wanted to have the opportunity for you to review for the rest of us.
Yeah,
As well as the public.
so this is a modification essentially of one of the files that DHHS sent us. One of the questions is where we're gonna get information again. I want to wait till I bring that up. Yeah,
There you go.
great. I apologize if for the small, can you zoom up like maybe a little bit more to get one row there. I think that was analgesics, wasn't it? The first row on the left. Let's go all the way to the left, yeah. Analgesics, and then just a little bit to the right so you can see the graph. Okay, perfect. This is a report that DHHS sent us from the file of prescription drugs. And the actually, I having a hard time reading it. My contribution essentially is the graph on the right, which is a frequency graph. And the argument that I'm trying to make here is that and actually this is a therapeutic class. It's going to make more sense when we get down to the generic table. But you still get a bit of a story here. The concept is to see where in a range of prices, and I'm looking at the price payment, average patient payment per day of supply. So we're using the unit as a comparison, is how much it costs to be treated by a drug. This is therapeutic, or it could be generic per day. So that's sort of one basis. That information was included, but not the frequency distribution of the report that was initially published of that average payment per day. And this is patient payment. There is also over to the right, you scroll over to the right, the actually the distribution of patient payment per day of, did I label that wrong? What's the difference between patient payment per day? Oh, this is the fiscal year 22. Yeah, so let's step back and say, you know, what is it we're trying to do in the board? And one of the ways to think about what we're trying to do is to get a sense of where there are opportunities, where there's indication from the market that patients are paying a lot for a drug versus paying a little for the drug. And if we think conceptually, a way to start out with, as when we look at a generic drug, if, for example, the distribution of patient payments or the distribution of payments across the board, that is what the prescription or the pharmacies are getting paid for drugs. When we see a distribution that's vastly different between payers, or where we see within a particular payer of a wide distribution of payments for a single generic drug, that is a way to identify opportunities for savings. We have to be a little bit careful as we talk about rules. If we worry about just the ones that are high, the people who identify themselves as being low payments can say, hey, wait a minute, we can charge more and still be below the average. So we need to be worried a little bit about how we frame stuff. But the attempt here is to identify situations where there's a wide range of payments for drugs. And the easy way to do this kind of visually is to just put up a frequency distribution from the data itself. Frequency distribution that compares that looks at 2020 and 2021 to see where there are differences, where things have changed over time.
So in saying that, by looking at that distribution, what I'm concerned about is the shift to
Well,
the
there are two-
patient. Is that if we're seeing over time, the
Well,
patient,
we've got two rows here. So are you looking horizontally or are you looking vertically?
I'm looking at it horizontal at this point in time, but
Okay,
as we
yep.
look at that horizontal line.
Yep.
net distribution, looking at that over time as well. So we're adding now a time element and looking at that distribution, because if we're seeing that the patient's payment per day supply is going up, but the overall cost has not been going up totally. What that would tell me then is the patient's percentage of the overall price is going up. So they're paying,
Yes.
they're paying a heavier freight.
Yes,
It's what I call cost shifting.
yes.
So we're not, the payer not really doing much to reduce the cost. They're just doing what I would say fundamentally is shifting the cost.
So,
And so when I listen to a PBM and come in and talk to us about how much they've reduced the overall cost, the cost to them, yes, the cost to the patient, maybe not.
one of the reasons of, I'm following HHS's, initial table in which they printed the average, provided to the board, the average cost paid by the payer, or the average payment by the patient versus the total payments paid. That's the over to the right. Why don't you scroll over to the right a little bit more? We've got, oh, that's the change. I think I've got a table, one of those charts should be patient payments and one should be total payments. And I'm worried that as I look at this now that I've got the labels mixed up. We should have a frequency distribution of total payments.
Yes.
And a frequency distribution of the patient contribution of those payments. And you're exactly right. If you see a shift over time in the patient outlays payments and not in the total contribution of total payments, that's cost shifting.
And part of the reason I want to get to that understanding, as we shift more of the cost to the patient, the concern I have or would have is that if they're not taking the medication, they could be leaving the medication at the pharmacy. So the fill rate could be a problem where all of a sudden you're shifting it more to the patient, patients pick up more of the freight, but the unintended consequences also the patient can't afford it, which means that they're not taking medication, which then leads to other issues, medical and otherwise, hospitalization and so forth. So even though in the short run, it looks like we're saving money by shifting it to the patient, the system as a whole.
My contribution to the world is pointing out that when Medicare stopped paying for the immunosuppression medications, the patients in low income counties died, lost their grafts.
Yeah.
So, yeah, exactly right.
So it probably for us here at the board is try to understand what are the data points we're trying to get to help guide what we're trying to accomplish. And that's what I'm trying to understand is that there is the overall cost, but there's a cost, if you will, to the patient. There's a cost, if you will, to the plan, because they're bearing some of the cost as well. I mean, that's one of the things we talk about in rulemaking. How are we going to look at what kind of data points to sort of set targets?
Do we need to be exclusionary? Can we not look at both and identify perhaps cases of cost shifting at the same time, or it's, you know, a different chapter where we are identifying the payments, the aggregate rise in total payments?
Doesn't have to be exclusive. No, it could be inclusive.
Yeah, my sense is we are both worried about aggregate payments,
Mhm.
the budget for the state, the prescription drug expenditures total rise, and we are also worried about the amount that patients pay and the affordability and the implications of not being able to make those payments.
So if we're looking at the public payers, of course, the state itself is a large public payer, along with Medicaid, is another one that comes to mind, is looking at those data sets. Because that's really what we're focused on. what happens in the commercial market, they can learn from us, but our focus really is on public affairs. Is trying to figure out how to help the state become a good steward, if you will, the resources, tax dollars, if you will, how we're spending it on the drug benefit. Is it actually getting to what we're trying to get to?
Yeah, so, excuse me for, I would hope that we would not exclude the commercial market.
So we can include them, but
In
we
the
can't,
analysis.
but we can't set targets for them. We can use, I think, commercial to help us when we're doing our target setting for the public affairs. But for the most part, we can't really set a target with commercial, but we can, at that point in time, the commercial market can look at our targets and figure out if they're in line with what we're recommending.
I'm an analysis person, I'll present stuff. And, within the purview of the board's ability to provide information and hopefully be useful.
So what do you recommend? I mean, I don't want to boil the ocean, as the saying goes. Get so down into the weeds that we lose in the sight of the forest. What are your recommendations? What will we do as far as the data points? What are we trying to get to try to help set targets?
So I think the legislation talks about asking HHS for 25 of the most expensive therapeutic classes and 25 of the most expensive generics, if I recall correctly. And it would seem to me that asking HHS to do something along the line that I proposed for those 25 would be a good starting point. I mean, the trouble with any kind of analysis is, as soon as you do the analysis, you leave yourself open to what about. There's a buts, there are qualifications, there are data limitations and analytic limitations.
But don't you think, don't you think we have an ability, given the numbers and the sample size, that you're gonna be able to make some reasonable assessments to deal with some of that ambiguity? I mean, statistically.
So qualifications, there are going to be qualifications across the board. Am I optimistic that by doing the kinds of looking at frequency distributions within generics, that we'll be able to ask some questions about what's going on? That would then, depending on the answers we get, lead to possible actions of one sort or another.
So that is our charge,
Yeah.
to figure out some analytical framework for getting a handle on this, for public payers and spending.
Right.
That is our charge.
Yeah.
So I suspect, to your point, there's gonna be various mechanisms for doing that. So this being one.
Yeah,
frequency
exactly.
distribution.
Yeah.
And would you envision others? I mean, you're gonna have a toolbox of tools to help us get our hands around this.
Right.
Looking at disparate data points and incomplete data sets, because from what I've seen so far, that's where we are. We don't have complete data points, and it's not a knock on anybody, it just doesn't exist.
Right.
So there's a construct we're gonna be building.
And even if we had quote unquote completed, they're also, within the kidney transplant data, excuse me for keeping going back. Their self-reported race, black or African American versus white. Whether you're an African American in the US, these are complete data sets. But whether you're African American in the US is a whole different thing than if you're African American in Brazil. In the US, if you've got a quarter or an eighth of black blood, you're considered to be African American. In Brazil, if you've got a quarter white blood, you're considered to be African American. It's just, so there's no perfect data set. But there are answers that we can come up with the data that we have. And if you ask whether I'm optimistic about the board coming up with identifying generics in particular, and maybe therapeutics, where there seem to be discrepancies that merit investigation as a possible sources of cost savings. I would say yes. And
One of the other things it talks about here in the statute is that when you look at spending targets, is also to look at medical cost offset. And part of that is if we're seeing an increase in the drug cost, but we're seeing a double decrease in medical cost. That's a good thing to happen. If we're seeing an increase on the prescription cost, but the medical costs continue to double, then it's not a positive thing. So how do we correlate between, I don't know, what the data set is saying, okay, we're trying to encourage as much as possible appropriate utilization of drugs because we know when they do it correctly, there's an offset in the medical cost. So how do we correlate that part?
when we get down to therapeutic classes, we have talked about going from therapeutic classes to generics. But the framework that you're talking about is not therapeutic classes of drugs, but diagnostic categories.
Right.
Again, one of the early papers that I did was, I'm going to forget the name of the drug. It was OKT3 versus another drug. It turned out that I had a running buddy that was a transplant nephrologist who complained the hospital wouldn't let him buy this new drug. And I was able to show that by using this new drug, the transplant patients were getting out a day early, which was much more expensive than the new drug itself. So they were saving money. So with AIDS, for example, AIDS, some of the AIDS regimens have drastically reduced the cost and increased the longevity. You're quite right. Perhaps we should, in order to grapple with what you're doing, not only pick generic therapeutic classes, but maybe some diagnostic categories where we could look at total expenditures in those diagnostic categories.
I wonder if a good roadmap would be what our deliverable is. So we have a deliverable. We're supposed to be publishing a report, right? So we could back into what it is that we ought to be building so as to deliver what it is that we're doing.
And that's kind of what I'm trying to tease out here.
I agree.
And it may well be that we have incomplete data points for some of it, and that's reportable too, though. Right? I mean, that is an important piece to report out to people, because it is our charge to try to get a handle on this for public payers.
Part of it too is that when you start looking at drug cost and look at the components of them, is generic utilization is a big part of it. And that gets back into the same thing with power of the pen, and that's the prescriber. Is how are we doing with educating the prescriber about the utilization of generic drugs, because they're as beneficial clinically as some of the newer ones. They haven't. Pharma's going to be out there marketing all the brand name drugs for all the obvious reasons. And we talked about this before, is at the medical center. The reason why there's so many brand name drugs in the medical clinics for samples is because they're left there. Would be beneficial to the hospital to give the physicians generic drugs and pay for it. Because then they'd have samples to get the patient started.
Yes, I agree.
So teasing this all out, I mean, I don't know where to go with your point, but where to go with the objective and back ourselves into it. And try to set spending targets. I think we try to. Is it a macro target we're trying to get to, or are we looking at taking maybe a diagnostic group and setting a target specifically for that group to help start the process? I mean,
That's a big board discussion, right?
it is. I mean, how if we start too large, it's gonna, even the resource and so forth we need to get there versus taking something that's maybe diabetes and working up from that, which is high in cost and high in utilization. Go ahead.
It kind of focuses back to this report, not because I'm trying to sell this report, but we do have a data set.
Yes,
And we do have HHS willing more or less to provide analyses from the data set. And if we could agree to I guess the appropriate thing would be to start negotiations with HHS about the form of the report. That could be something that could be started. At least I think. So I think my proposal would be to enter into negotiations. Did you were checking the legislation for the 25 therapeutic classes? Did you find that?
it's not therapeutic classes, it's 25 most frequently prescribed, 25 costliest, and 25 with the highest year-over-year.
But
increase.
25 of what? Was it therapeutic class or
Wasn't by
generics? Or
Doesn't say anything, it just says 25 most frequently prescribed drugs in the state. Most likely those are gonna be generics because that's really where a lot of the utilization is going to be as far as looking at volume.
Because HHS provided us with a variety of interpretations of that in this report. They did give us a table of therapeutic class. They did give us a table of generic equivalents. Which seemed to me happy if I were to pair that, I would focus on the generic equivalent. And, you know, say, okay, we're asking for more information, more work. But let's focus on the generics to start out with the generic equivalent. That would include the brand name man. So you'd expect to see on the frequency costs, you know, some clump at the low end and some clump at the high end where the people are still paying for the brands.
We could. The challenge to see it here, though, is that when we look at a particular therapeutic class, we not capture all the 25 drugs by volume, because they may be spread across multiple therapeutic categories.
For a DR or for a diagnostic category you're talking about? I don't know whether the data supports sort by drugs by diagnostic category. That's incomplete. Yeah, is there, so incomplete can be.
A lot of missing data under the DIG variable. The effect of that would be multiplicative in the pharmacy claims data.
Right, so do they have, when they don't have DRGs, which is a hospital, do they have an MDC, which could be outpatient?
Yeah, the NPC.
Pretty good. Okay,
Because the query on that, not the DRG.
yeah, DRG is limited to the inpatient hospitalization, so that is exclusionary starting. So by the MDC would be possible.
NPC.
Yeah. Major diagnostic category.
The challenge with generic drugs, though, by
NPC.
Yeah, that's what I'm calling.
And that's their drug category.
No, what I'm talking about diagnostic. There's nothing about diagnosis other than DRG.
The DMG. And then the ICD code in grade 1.
Okay, how complete are the ICD?
Fairly complete, primary, secondary.
So if we had a grouper that could look at. I mean, you get into problems of, you know, if you've got, you may have chronic kidney disease and diabetes. How are you going to, is that diabetes or is that kidney disease? So there are that kinds of things. If the ICD-9s are, how many fields of
There's
ICD?
10 in the first 3 are well populated, after that. Who knows, 90+% missing data for the fourth and 10th.
So it would be possible to run a group of some sort of, to pick out people with diagnostic, with diabetes. There would be people with diabetes with other diseases. Or congestive heart failure. I mean, you could do a whole bunch. So we could come up with. Not, I mean, it's going to be subject to a string of whatabouts. and qualifications. But it looks like we could come up with some major diagnostic categories of some sort. And then ask the question, what are the drug expenditures within that? Or do we have the legislative authority to do that?
Well, I think one of the things was that targets, it doesn't say specifically what it's focused on. What it does say is in the report that's generated each year, the report has to include the 25 most frequently prescribed drugs in the state, 25 costliest, and then 25 for the highest year of the year. That goes into the report, which could be different than what we're doing here, but that's required by statute in the report, which we can do. I think we do at that point in time is just go back into the data set and just pull from the data set and say, okay, what's it? If I can pull you into a second, is that at that point in time, you can quickly identify by volume which ones are the highest volumes, which ones by dollars, and then which ones have the highest increase year over year by going back and looking at trends.
So the definition of volume is a little bit unclear. I have used days of prescriptions coverage as the definition of volume. Is that acceptable? That's opposed to scripts, which is the thing that's originally on the data set.
It needs to be scripts because it says prescribed. You might
No,
add- right.
But I'm talking about prescription, days of prescription drugs.
It says most frequently prescribed drugs. So I would take the word prescribed, meaning each prescription, something that's been prescribed. However, you bring up a good point because you could go back and look at the number of days supply. So it's not the active each
You can get
prescription, but
90
looking at how many days were prescribed for that point in time.
You can get 90-day prescriptions easily, or you can get 30-day
30 days.
prescriptions,
Right.
right? Or you can get week prescriptions.
Correct.
The value of going to the day is giving some cross representation of that. You know, for a week, it'd be 7 days. For a month, it'd be 30, for the 3 months, it'd be 90.
I think we should probably in our rules and define what prescribed means. If there's something to think about.
Or the volume, I think, yes, what the volume of prescription means.
We're talking about number of tablets, number of days supply, number of prescriptions. I think we need to define what that means.
So I'm proposing as
What would you like?
days of
Days.
coverage, prescription coverage. I mean, there, what about that? I mean, you know, some people are really sick and get a high dose, and some people, I just had a steroid prescription. The first day was 6 pills, the second day was 5 pills, the third day was 4 pills. You know, in my view, that would have been a 6-day prescription.
So again, back to definitions here, because it's going to lead us towards what we're
Yeah.
trying to put reports. You say the cost of your drugs. Is that going to be a total amount of the drug spent, total amount? What do we want to use?
We
Yeah.
really should, the word cost in healthcare economics is just such a bad word. It should be stricken from the vocabulary. We should make people think. We're talking about payments. So this is payment, not cost. And this is payment, I'm arguing per day of script.
Makes sense. Is that going to be the total amount, including the patient, right?
So the HHS report split out the patient from the total, from the payment total, which I thought was appropriate.
Is that correct?
I don't know that I agree with that.
Which one?
Well, I think the whole framework using days is the time actually using the anti-diabetic, by the time you have insulin pre-dog and GLP-1 inhibitors that are taken once every 7 days with effectively the same therapeutic effect.
So that would be a 7-day coverage in my house.
Should be.
Yeah, I'm not sure that using days as the timeframe for the cost of the payment for the effect is homogeneous across all therapies.
So. I agree.
Yeah.
The question is, if we've got to pick something.
Yeah.
And fly with it, even though,
Maybe it's not a time measure, maybe it's a more qualitative measure that relates more to the opportunity cost for for foregone medical outcomes if you were to decide not to take the drug based on loss. Like qualities are easy, so qualities is an established reference measure that's ubiquitous in the industry.
Right.
That kind of gets more precise and closer to that than just some arbitrary number of certain amount of time.
I am a big fan of quality.
Yeah, and EV.
That said, is it in the data set?
It's not in a data set, but there's reference information that ISO publishes for almost all ubiquitously used
As
drugs.
much as like to do a doctorate on this, I don't think we have the resources to get there. But I hear what you're saying. It's a very
I
valid
agree
point.
with the concept.
Yeah.
Concept, I totally agree with the concept. I just don't know if we have the resources to accomplish it at that point in time.
And we're focused on cost.
Yeah.
Not.
Well, cost per quality analysis is what ISO does when they publish the data. So it's pretty. Good with it.
So again, we look for, I hear you saying about the day supply, but normally in the pharmacy, we fill a prescription, you're putting in the number of day supply because it represents something. You have a violence and it's gonna be 30 days, you have to put something in there because the field requires it. So that's gonna be captured in the data set. Now we can make.
So if you have an insulin, yeah, that's the question. If you have
The
a
pharmacist is
7-day,
required to put into the field a number of day supply. The reason for that being is that's what the insurance company uses before you can get your next refill. It's required,
so if you have an insulin shot that lasts for 7 days,
yes.
does the pharmacist put down 7 days in there or one shot?
7 days.
So it should come out. So the per day is a possibility.
They have to, because the reason that is in there is that when you go to refill it, they want to know whether you're refilling it too early, too late, that's a benchmark. And that's also causes problems because if the prescriber changes the directions with the patient midstream. And they go into fill the medication before it's supposed to be up for refill.
Right.
They run into a problem because the payment stops. Because now you're getting in too early.
Yep.
Even though the doctor told you to double your dose.
Yeah, right.
But
So it's fresh eyes, which is good, right? Because I'm not a healthcare economist, nor am I a pharmacist. I applaud that you're both those things.
You're characteristic of the rest of the world.
But maybe yes, well, I speak for the rest of the world, right? On my own behalf, without any authority. I think we need to be very careful that we don't sort of try to solve the problem through the current construct that is obviously insufficient. Okay, I'll put that out there. I mean, we have got to think to dig deeper and find a better way to say everything you're saying. I understand it all. I think I do, but if you're taking a pill, what does that pill cost year over year? What's the difference? Which pill is which one of those many thousands of pills gets taken most frequently in New Hampshire? So I just think that the data sets are inscrutable from what I can even gather. Now, again, I'm not a healthcare economist, but there are gaps in the data, and for whatever reason, right? There's not any,
Right.
I'm not casting any aspersions.
I agree.
But I do think we need to figure out a way to look at these. Just think about one pill. What does that look like? I guess what I'm saying is that if we get caught up in everything that's happened, that's made this almost impossible to measure. If we're going to stay with that construct, I don't know if we're going to get the traction we need, right? And when we were thinking about drafting rules before, one of the thoughts we had was making sure the board had the ability to be a little more creative, consistent with its authority, within the grant of authority, to do what it was that was expected of us, that was passed in a bipartisan way to get a handle on the cost of prescription drugs for public payers in New Hampshire. That is our charge. So maybe I'm saying the same thing, but I do fear just using the existing set of data and the way we've measured in the past, because I don't think it's been able, I have yet to be at a meeting where we have any clarity about how those costs have increased or decreased over time. Everybody says something different. So our charge is to try to figure it out. So it might be a new approach. So I'm so glad you're here to bring your wisdom on it, because I don't know. But what I think I do understand is that it's almost impossible to figure it out. And this is nothing new. It's the same kind of thing for years. This has been an issue with healthcare. So I once put it to a fine physician who ran a large private foundation in New Hampshire. I said, where is every $1 of healthcare going in New Hampshire? Everybody points to everybody else. Durable equipment manufacturers, it's the lawyers, it's tort reform. It's the insurance companies. I find it very hard to believe in 2022 that we cannot figure that out. Right? Just somebody can figure it out. We can crunch enough data to put people in space. We can figure that out. We don't want to figure it out. We just don't
Well,
want
there,
to figure it out. That's it.
I totally agree with your concern. My suggestion of this patient payment per day and total payment per day for a prescription drug script is my intent. That I think the concern that you have, if this is not, if this approach bothers you, let me bounce the question back and say, what would you think would explain it?
I don't say it if it bothers me. You know, I mean, really, I'm just suggesting that it might be several different approaches.
I agree with that. I mean,
Yeah.
keep going. So, go ahead.
I think one of the things, if we can go back to, that we have a report that's gonna be submitted, so in the report is a requirement for the 25 most frequently prescribed drugs. We talked about a definition of base supply. Because they're just talking about the report now, not the goals. We have to get a report done as well. Costliest drugs, again, the same thing as payment per day.
Total payment and
Patient
payment. It's two
I
measures.
just want to capture this,
Yeah.
okay, total, and then patient. Okay. Then 25 drugs of the highest year-over-year cost. Can you get that within the database? Let me go back and look at. Again, we're looking for payment per day of drug, total and patient. I look at the total, because that's really the cost.
Right, that's what they.
Cost of society.
Public pay, exactly.
Correct. What the public payer is gonna look at the public payers part plus the patient side and track that over time. So looking at 20, whatever data set we have, if it's 21 compared to 20. Or 20 versus 19, whatever it's
We
going
can
to
go
be.
back farther than 21, 99, or not 90, but 20. The New Hampshire Insurance Department, HHS, I think. So it's, you have a contract with HHS, right?
You being the board. That was is that a question for me?
You keep looking to me and saying
HHS.
HHS, I'm not sure.
Oh, you're
The insurance.
Yeah.
Right.
Yeah,
I
and
think that you
Yes.
have an agreement with the Department of Health and Human Services to do
Right.
data analysis, actually, should data.
I don't know the department well enough to know if there's anybody.
that would be Andrew.
Andrew and Mary.
Mary, we
Yeah.
may have to have them come and help us.
Yeah,
What's the
or
data set?
meet with, perhaps meet with them separately. I'd be glad to schedule something.
So as long as we have some definitions, we need to bake them also into the rules. When I work with Alice, and I'll be sure those get baked in. At the same time, we talk about the highest year-over-year cost. The cost we're gonna use is gonna be total payment or correct. Because the payment really becomes the cost. So the
The word cost is just like
it's total payments made.
to whom you're talking about.
So I'm all set with that.
Total and total per patient.
So
And
regular
per day,
on a daily per day. We're stay with it per day.
so actually, from the aggregate point of view, perhaps we could simplify by just looking at the aggregate per year.
If you want. I'm okay.
I don't know what the aggregate per day is going
Per year.
to add.
Per year.
Yeah,
Again, total. And then total by the payment by the insurance company and total by the patient. I think we
Yes.
need to be sure that we don't leave the patient out of there, because
Exactly,
we have two different payment streams.
yes.
Yeah, because the other piece is for the efficacy of the data, right, to what we're saying, you don't wanna, if you went by day, wouldn't you want to have some kind of smoothing for, you know, some supply chain issues and stuff?
Correct.
Obviously, wouldn't a 1 year period have more reliability in the increases? Or maybe I'm forgetting my statistics.
I agree that the data that HHS did provide was over a year's period. How much did the patient pay per day of script coverage?
So if we look up here,
That $1.97
if
is,
you look at the column, it starts with 6 million.
okay?
That's the total amount that was paid.
Yep,
So at that point in time, that's the aggregate for the year.
yes,
So we're gonna be looking at that number compared to what's going on with 2021.
yes,
That's gonna be year over year.
yes.
So we're gonna go back and look at fiscal year 21.
So I would hope that they would be willing to run, you know, if we get some code that's designed to create these results for 1 year, adding 5 years. The question is
Right.
how far back the data is good, but the extra cost in terms of time and paper to run 5 years versus 2 years, if the data supports it, is negligible. So that we could look at the cost increase over time.
Over. But it requires year over year, so we could do that
Yes.
over, if you want to use a 3-year horizon, 5-year horizon, fine.
Again, this is subject to the data being suitable, but there's been trouble getting Medicaid into this data set. So, you know, Andrew might come back and say, you know, we only believe our Medicaid data the last 3 years or something. We have to be sensitive to that.
So what I have right now, this is again back to the report that is required to be submitted. 25 most frequent prescribed drugs, we're gonna use day supply. Costliest drugs, again, based on day supply, and we break it apart into total. And then payment by patient.
Maybe you ought to run the text by me because I wasn't quite clear. We want to look at the first column over there, which is the aggregate for the year overall patients.
For the costliest ones,
Yes,
yes.
yeah,
But for the,
yeah, that's what, all of these are costliest by one of these methods. The table of the costliest by aggregate expenditure, aggregate payment. And the table by the costliest to the patient would have different row labels because it'd be different drugs.
so we talk about the 25 costliest drugs based upon the aggregate spend for the year.
I would argue that we should do both. I have in my head the concept that we're gonna have a chapter about aggregate
Okay,
in our report and a chapter about a payment per patient, you know. What the cost to the patients is.
that's the report.
That's a piece of the data.
All right, so that's there. The other part we're looking for is. When we start looking for setting targets, this is just reporting historically, which is really looking to review mirror. Now, if we're looking at the front of the car, driving down the windshield, what are we looking for as far as setting a target? And I think at that point in time, if we're gonna set a target, is going back and looking at. Maybe in the aggregate and saying, this is what you're spending per patient per month. Which is numbers quick you can get hold of. And saying, based upon inflation, based upon the rebates and so forth, we are trying to set a target. We think what's reasonable for an increase is looking at that and saying, okay, per patient, per month, drug cost has been this. Based upon these parameters for the next year, it should go up by 3%, 4%, whatever it is, based upon these parameters.
It would be our expectation back.
Yeah.
Maybe,
Yeah.
I mean, obviously, we're not setting prices. We're very clear about that. These are just targets.
It's just target. This is a reasonable increase that we think would happen in the aggregate, and not get involved with the mix of the drugs and this and that and so forth, saying overall. What we have seen, the trend, or what's going on with the data sets we have based upon medical cost index, et cetera, et cetera, et cetera. We think at this point in time, a reasonable target is to see an aggregate increase per patient per month of X. Well,
I really like your, what I call major diagnostic categories, concept. And one of the troubles is if you were to have looked at AIDS, the AIDS, increase in the AIDS prescription expenditures was huge as they figured out what drugs would really control AIDS. And it's possible that we're talking about, we have ongoing a great deal of research into vaccines for cancer. And it's possible these will come out that will be really expensive, but will cure cancer. So I really like your diagnostic category. So can we have a chapter on cost per patient? Patient payment per patient, aggregate to Medicaid and public payers, and a chapter on selected diagnostic categories. So that
no, we can't.
if there is something going on that allows the drug company to cut back on hospital expenses, that we don't fall into a trap of failing to recognize the savings opportunities in that higher drug expenditures.
So looking at drug expenditures, and back what he's mentioned before, is a component of the overall medical cost. Because if medical costs are going up by this, but drug expenses are going up twice as much, then I'd ask the question, well, we're spending a lot of money on drugs, we're not seeing a lot of decrease in medical costs. That's not looking at it in a diagnostic category, but looking at it and saying is, if we're really trying to put our resources into pharmaceutical utilization, we should be seeing it somewhat a tapering of the medical cost if they're being done correctly. Otherwise, it's just, we're just putting money into the medications, but we're not seeing any offset over here. Probably.
Perhaps we should have maybe we could have a Zoom call kind of thing,
Yeah.
where I talk a little bit about what's going on in aggregate healthcare expenditures. I started down the path that you're talking about and looking at, I do some graphs for healthcare expenditures in the US over time, and prescription drug expenditures over time, and looking at prescription drugs as a percent of healthcare expenditures, and healthcare expenditures as a percentage of GDP.
Right.
And the rise in healthcare expenditures as a percent of GDP is a surprisingly straight line since 1932. If you draw from 1932 through 1964 as a percent of GDP and extrapolate that up into the current year, you've got a very predictable, we're only a percent or two off of what you would have predicted from that early.
So what was it back in back in 1932?
There's a big report that talked about the problem that the US was going to have if its healthcare expenditures got over 2% of the GDP. Stuart Altman made, somebody who I worked in the HEW in the 70s. He made his career talking about the sky was going to fall. We got over 10% of our GDP into healthcare expenditures. We're bouncing off of 20% now.
And has the percentage of that overall cost of healthcare, what percentage has drug therapy been?
It's interestingly, drug in the 60, I think it was, where the new data is available, was about 10%. In the early 70s, it dropped to about 5% when the drug companies went back to direct-to-consumer advertising. it went back up to 12% or so. And it's been fairly steady at, 10-11% since. So, I mean, this raises a question. I've got explanations of what's going on that's above and beyond the prescription drug. And I tried to find New Hampshire data. The trouble is New Hampshire data is mixed. We don't have the GDP for the same year as we have prescription drug expenditures, and different people, different agencies have been responsible. But my early results suggest that as a percent of GDP, New Hampshire historically has been lower than the nation as a whole.
So out of curiosity, when I hear the 12% of total cost, is that before or after rebates?
So if that,
It's a black hole.
so what you have is a guy that can look at numbers.
Okay,
And it acknowledges that there are all sorts of problems in the numbers. So the numbers that I'm looking at the national level are published by HHS. And I don't know how the prescription drug is handled with respect to rebates. I don't know whether they include it or not.
No.
I could try and ask and investigate that,
but as public payers, my understanding is that if the rebates coming back, what's going to Medicaid, what's going back to state insurance, those rebates we should be aware of. Right?
I'm confessing to a lack of knowledge of whether that is in there or not. I can look at, I can
I don't think it's
read
in
the
the
fine
data,
print.
but we should be able to get that data from somewhere because it's reportable. Rebates that go back to Medicaid go back into the Medicaid program. So we should be able to work with the Medicaid program to get the rebates. And we also should be able to see what's going on with the quote rebates coming back with the state of New Hampshire for its employee program. What I'm trying to get to is that starts closing that black box because we have visibility into the black box.
Right.
Then we start looking at overall cost, which is what we're trying to get to, net of rebates. Because that's always been one of the things here. We set a target as a target, but then we also need to look at what's going back as far as the rebate component.
Yeah, I think we should also remember, we're gonna be writing for, we're writing for policymakers, somewhat of a lay audience. We're writing for people who are gonna be reporting on this. And we need to make sure that what we actually generate is intelligible, right? So
Useful for their.
it's really important that we do that.
So I think the answer to the question you were asking is that we add a chapter on the selected number of diagnostic categories that look at prescription drug expenditures within the purview of the total cost. So the pharmaceutical companies were very good at showing that their AIDS drugs were really expensive, but the total cost went way down as a result of their being around. There are certainly some categories where we could look at that. Some types of diseases. There's be useful.
We want to think of this point, a large dollar spend and a large population involvement is diabetes.
Yeah.
I'm not saying it's the one to tackle, but I think it's the most germane on the table because everybody's focusing on insulin cost and very frankly, how we what do you call social determinants with how we eat and so forth with diabetes.
Yep, I agree. There are lots of complications of diabetes that make it more expensive, such as kidney failure.
Definitely some work. So would you be willing to help out with
Yes.
creating these reports
Yes.
for the report?
Yeah.
Thank you. Any more discussion? I think we're making progress. Todd, what are your thoughts? I think we're going down to look at the macro level. Just trying to understand where we think a reasonable target is, and that should be set as much looking at the rebates as well. So we have to be looking at the aggregate. Because I think that's what we can make a recommendation. We set a target, it's more of what the aggregate spend is going to be. And not get into the weeds, because once we get into the weeds, we're gonna get lost.
We will, but over time, I do think it's gonna be iterative and I think we will get more clarity as we build a model and get more familiar with the data and the reporting. And it may well be that this process illuminates, frankly, I hope it does. It illuminates where the gaps in data are and how we can fill in some of those gaps in a way that's fair all around. So to your point about, the AIDS drugs and insurance, I mean, there's been innumerable savings, and you can't even think about the cost of savings in human life and everything else by virtue of that. So I'm not sure if that's fully our charge, but it's a fair point, right? It can't only be that one piece that it's, yes, they're boosting every year. We have these experimental drugs. Now all of a sudden cancer is something of the past. Well, what's the cost there? And what's the cost savings there to a system? So it's a fair point.
And the other thing we're looking for is quite frankly, it's gonna be the final payment. What I'm trying to get to is when you start looking at the whole supply chain. Pharma starts it, but it doesn't end there.
Mhm.
So you're gonna have pharma with their slice of the pie. You got distributors with their slice of the pie. You got pharmacies with their slice of the pie, the patient pay with their slice of the pie. And you also have rebates, which is another piece that brings the pie size down. But I think we're looking at a chart and saying, okay, this is what we've spent based upon the data. This is, pharma's getting, I don't know, 50%, 60%, whatever the data shows. And at that point in time, this is what the pharmacies are getting, what wholesalers are getting, and what the patient's paying, because I think it's sort of a pie chart over time is how that's changing.
That'd be great.
Maybe it's too simplistic, but it's more of a,
In my sense, it might be another chapter that's. It's an excellent question, and we anecdotally believe there's a lot going on in that pie chart over the years, and it would be, I think, valuable to see how that chart has changed over time. I have no real expertise.
and that's, I think we're trying to find is where's the data we can start building a pie chart.
Yeah.
And looking at the other side of the coin, when you look at that pie chart as well, are we seeing a shift from go back but with pharma to the rebates? If all of a sudden we're looking at the payment, but pharma's getting less and less slice of the pie, and the pharmacies are staying stable, then where's it going? It's sort of putting a spotlight on it and saying, this is the pie, this is what we see. And one of the things we could do, it's available to us, is back the same thing with specialty drugs. Not that I want to open that can of worms right now, but in a lot of things that are administered in Part B, which is office administered products, or in clinics, Medicare does release every single quarter the average selling price. So you can we could benchmark some of these cost lists one part and say, based upon what the data is, this is what is being reported by the government on the average selling price for that drug. This is what a payment is and how that's changed over time. Because that's really showing what pharma got. That's their slice of the pie.
Do they report that by state or just national?
National.
And we do want to get it right.
Yeah.
I mean, I like that you're saying that. I mean, I think there are talking points from every different sector, right? But let's get it right. Let's figure out to the best of our ability, really what is happening over time. Like really, if it's pharma, then let's call it out.
Yeah.
If it's the PBMs, let's call that out.
If it's the pharmacies, call it out.
Seriously, call it all out. And so that people can just know. But I think our charge is to really take it out of the darkness that enshrouds it now. It's just not, it's almost inscrutable, all this data. Maybe not for you. There's not a lot of healthcare economists out there.
No, it's not. But one of the things I will say, I was on a call on Friday, and this is now publicly aware, it's public information, but NASP, National Academy for State Healthcare Policy, has had an RFP out, and they're working with a company called Portal, which is actually the division of pharmacoepidemiology and pharmacoeconomics at Harvard Medical School. And they will be working with us, got the same thing, probably with you more than anyone else about. But they have a lot of data sets down there. They've been following all this. So the good news is we are now going to have a resource available to us.
It's great.
To do that. So
Yeah, but if we get reports from or data from them, are we paying for them?
it's coming through NASP right now. the question, if we're looking for specific reports for what we want to do, we'll probably have to pay for it. But take their canned reports that they generated, then most likely that's not going to be cost to us.
Will they give us access to the data set?
I'm going to give you a contact. I'm going to have you call her.
So, and where's, and this might sound like a silly question, but where's the, like, the peer review on all of this? I mean, I appreciate Harvard and Yale and all those places, but is there, I mean, how do we know if we're gonna look at to the point of getting it right? I mean, to the point of getting it right and making sure that those sources that we listen to are either reviewed or compared to other sources.
Yeah, a good question.
And you gotta start someplace, and I appreciate that, but again, I do take our job seriously, and so we do need to get it right and not come in with bias about who the culprit is.
You raise an interesting question. One place that peer review exists, not perfect, and all sorts of criticism, is in a publication, in a journal. One of the questions would be, to what extent are there publishable articles from the analyses that we do? And is that, are there restrictions? I had presumed that anything that would be done would be for the state, for the board, and not necessarily publishable. But one way to get a good peer review about the veracity and sensibility of what comes out would be to submit an article to a national journal and get their peer review. What's the board's stance on that activity?
We need the whole board.
Yeah.
I'd love to see that article. I don't think I could write it, but I'd love to see it.
And this is basically what they're charged to do for us is to educate the board members as well as advisory board on topics of interest, including but not limited to prescription drug pricing and policy, U.S. drug supply chain, clinical and economic evaluation of prescription drugs. Number two, identify costly prescriptions for potential board review through research and data analysis and develop criteria for selecting specific drug targets for affordability board review. 3, define an analytical approach for reviewing prescription drug affordability and conduct drug affordability review accordingly. And 4, when authorized by state law, develop consistent and transparent criteria for setting targets. So, I mean,
That's some peer review. That's some.
So-
Yeah.
so anyway, that's for us coming, hopefully, if you don't mind, to be in contact with them and sort of be our link to, that'd be helpful.
I would be glad to do that, subject to a certain skepticism I have about their likely collaboration with providing us with information without much cost.
You can talk about that academic side of the equation. I'll talk to them about the cost side. That's okay. So they don't get into custom things. So that's kind of, I think, where we're going at this point in time. We have another meeting on October 10th to go through the rules, if you will. I will then go through and work with Allison to put some of these definitions into the rules. So we have that as far as the report. Bob, you'll work on the actual data sets that have to go into the report. If you could help me with the report in general, that'd be helpful as well.
So can I talk with Andrew?
Absolutely.
Right.
Definitely.
Set something up to chat about this and
Mhm.
what he sees as their responsibility. The data set exists also at UNH, I believe, in Ned Helms's Institute on Health Policy and Practice or something
I
like
think it's probably the same data set. We're just different. people.
I presume it's the same data set, but they also
But no,
are they're not a for-profit, but they're in a, they don't want to do anything that causes a financial loss. So if I ask for different information, they'll be actually, one of the interesting questions, will they let me get the hands on their data set in their site? The answer is not obvious, actually. I existed sort of in the same building and under the same dean for 20 or 15 years and never got my hands on the data itself.
Okay, and public comments,
Behind you.
start.
Representative Merchant, I apologize. if I'm
Oh,
Thank you. My name is Curtis Barry. I represent PCMA, the Pharmaceutical Care Management Association, which is the National Trade Association for the PBM industry. I had a question that I had planned to ask during the comment, but I'd like to address this discussion if I may. First of all, a little bit of the discussion reminded me, this is just an anecdote, I think that fits in with some of the discussion, reminds me of a circumstance several years ago when a manufacturer came out with a new hepatitis C drug. Previous to that, if you had hepatitis C, my understanding is you took one drug, took it for life, right? For the period of your life. The new drug would cure it. And it was a relatively short period of time, but it was incredibly expensive, right? So these are the things that you have to weigh and to the point of the cost per day. If you're measuring cost per day strictly, that new drug would have raised a lot of red flags, but at what's the alternative benefit, right?
Unless you did cost per day of life extended.
Sure, in quality of life and, things like that. So it's just an anecdote. On this chart, first of all, I'd like to point out that in the far left and the far right columns are missing. But this chart looks at two different types of drugs, an analgesic and an anti-diabetic. And if I'm reading this correctly, as I'm just seeing it today, the anti-diabetic, the cost per patient per day actually went down. Right, so if we're talking about cost shifting and placing blame, I think we also have to look at benefits, right? We can't cherry pick different specific drugs and say, this is what's going on and it's really bad. We have to look at the whole picture. So I just wanted to point out that the cost per day per patient went down. But I want to point out two things relative to context in this chart. First of all, and I'm glad that the discussion then shifted to the various pieces of pharmacy reimbursement. If I'm understanding this correctly, on the commercial rows, that tells me that what we're talking about here is copays, in essence, right? Because if it's commercial insurance, these are not cash paying customers. So then you have to ask yourself, what's driving the copay increases, right? And what I'm looking at is, I'm an employer. I'm not being able to afford the rapid increases in the costs to me for either my entire health benefit to my employees or just a prescription drug. I'm needing, in order for me to be viable, to pass along the cost to the employee in higher copays. And what drives that is, right, we have to start, which I'm glad, again, the discussion circled back to this, is where do drug prices start? Drug prices start at the manufacturer. So following that process. The one wrinkle, which is the question, Representative Merchant, that I was going to ask, which I addressed to members of the board individually, was, and you mentioned it a short while ago, is the distributors. I think you've heard, this board has heard from everybody in the whole scheme, with the exception of the wholesalers, which is, it's outside of maybe the scope of the board, the primary scope of the board, which is the cost to the state, as a public payer. But what's relative to the cost of the pharmacies, et cetera, is what are the pharmacies paying for their raw material, right? Because that's not directly related to what you're seeing here.
But pharmacies are paying, not what the pharmaceutical manufacturers are paying, right?
Correct, right. You've heard from pharma, you've heard from PSAOs, you've heard from us, the PBM industry, which, I hope you've had a chance to see the presentation, Dr. Woodward. But what you haven't heard, who you haven't heard from are the wholesalers who are, drive the cost to the pharmacy. So thank you. I'm happy to answer questions now, but I just wanted to offer those ones. Thank you so much.
Good morning, Mr. Chairman. Heidi Cole with Gallagher, Callahan, and Gartel for AHIP. I just wanted to make, I guess, two comments or whatever in terms of folks you haven't heard from. Perhaps the Department of Administrative Services, given that their role with the state employee health plan. they made a presentation recently to the fiscal committee. I won't take parts of it, but clearly they have a lot of data in terms of, you know, their attempts to try to manage the healthcare costs in general and the pharmaceutical costs in particular. And then my other comment, which you've heard us say this before, but I'll say it again. There are a lot of prescription drugs, specialty drugs, which are very, very expensive that are administered in provider settings, clinics, hospital settings. They are drugs that cannot be administered by the self-administered by the patient. And there's plenty of literature out there that shows that the hospitals that under their buy and bill model mark up those drugs anywhere from 200 to 400+%. And so it's just another area in terms of looking at players where costs are being added and ultimately borne by payers and patients. Thank you.
Good point.
Can I ask a follow-up question? Then? So as you're looking, let's take specialty drug, just focus on them for a second. Those that are administered, that are IV, have to be administered in a hospital or outpatient setting. And you mentioned they double the cost when they. My understanding of the literature was that having the hospitals buy these drugs and administer themselves, as opposed to being prescribed by a doctor, can be cheaper than the alternatives. Have I misread that literature?
Yeah.
I've not seen that literature. I mean, what I'm referring to are specialty medications
Yeah.
that cannot be
Right.
administered by the patient themselves. So, you know, cancer treatments and infusion centers and that sort of thing where, so I'm not,
We're focusing on those.
yeah,
I work with Heidi, Donald Funstein. The literature that is prevalent in our research is just the opposite.
That the hospitals are the most
Yeah,
expensive.
it's the most expensive site of care to deliver.
So is the markup on those specialty drugs greater than the markup on aspirin?
Oh, I guess it depends on who's selling it to you.
Yeah, my sense is that the hospitals in general do mark up everything.
Oh, sure.
And that markup, while it might be more than alternative delivery mechanisms, might be actually, and I don't know, this is an interesting question. It might be less.
yeah, I mean, I think another difference is that with an aspirin, for example, that may be a part of a bundled payment for, you know, whether you're inpatient or outpatient or in a provider's office or the
Right,
clinic
right.
or whatever, but when it comes to the more expensive the drug, the more likely it is that it will be billed separately, apart from the administration and any other aspects of care for the patient. And so, and that is in the data set that was discussed earlier, so.
We can resend to the board a number of articles on specific costs of
Alternative
specialty drugs,
alternative delivery mechanisms of
delivered,
specialty drugs.
based on site of care.
Okay.
I think one of the things would be helpful, Paul was saying, if we could, in the data set, is it's not what's charged, it's what's paid.
Right.
So therefore, the hospital charge is a nice discussion point, but ultimately comes down to what was actually paid, because most of the time, most payers don't pay the charge, they pay some sort of contractor. But going back, I'm trying to get to is, if we go back and look at the average selling price, which is definitely been reported within HHS nationally. If you can look at the selling price per unit, this is back in the same thing as I go back with the data sets, because what's being reported is the billing unit. So I don't know within the database that we're capturing on the payment, if it's down by the billing unit or down by the payment for the drug we're trying to get to. Are you paying, for instance, a vial has 10 cc's in it? The billing unit is 1 cc. So you've got to somehow take that billing unit and gross it up to the 10 to get the charge, if you will, the cost of the vial. So if there's a way in that data set, you go back and look at it, the billing unit is $20, but the payment that's coming across on the other side that we're paying as a public payer is 80. Then somewhere between the manufacturer selling it at 20 and someone paying 80. There is a whole cast of characters in between it. And I'd like to know that.
Well,
Which is
wouldn't the
different.
all payers database give you the start on that information?
I don't know.
Yeah, that's where it is.
We were gonna look at that.
Payer is stratified, and it does vary by payer, but you have an amount allowed, amount paid, amount billed, and then you have 3 inputs to the cost sharing
Does it have a J code in there?
for J code drugs, yeah.
So the J code's in it. So if you identify the J code is the billing unit. So at that point in time, we could go back, a good example would be Remicade. Remicade comes in a vial of 100 milligrams. But you may end up having 9 vials per patient. So we go back and look at the average selling price for that vial of 100 milligrams. We can go back in the data set and see what we paid for 900 milligrams. Then you could go from 900 back into the 1 with the 1 back to the 9.
And clarify the point. If you have a prescription for Remicade. I don't know, what disease is that used for?
For Remicade?
Yeah.
It's used a lot of times for rheumatoid arthritis.
Okay.
Or
So
it could be used for Crohn's. It's
is that
autoimmune.
a injection that lasts for some number of days?
4 to 6 weeks usually.
So is that in the, I mean, is that 4 to 6 weeks in the information on the days?
On the,
Or is it just an injection of 1 day?
I think when it goes across, go back and look at the data set, but when you get into the medical side versus the pharmacy side, how they bill for things is totally different than how a pharmacy bills for it. So the payment methodology would be somewhat different. It may not capture the day's supply like you would in the pharmacy.
That's what I'm asking, right? So that if we started looking at specialty drugs, we are going to run into this problem that a very expensive injection, it might be essentially a prescription for 2 years or
Correct. There are
2
some,
months or
that
something
fall.
like that.
but what we can do, which is a good thing of this, is we can go back and look at that payment that's made. And look at what the manufacturer is putting out on the website is their average selling price. Because we know it's $20, because it's reported. Okay, at that point in time, and that's after all the rebates and so forth, and that's their net price that goes through Medicare, okay? If we know it's $20, but then we go back and look at the payment. And look at the delta, because between the 20 and 80. You've got all the other players in the supply chain that are adding to that cost.
So I think my recommendation to the board would be that we focus on what we know we can get right away.
Yeah.
And then at the same time, we start talking about what we can get on prescription or on the specialty drugs. And what that data really looks like.
Right.
And how hard it would be to get this, this dose duration. Supplement to the prescription. I mean, that, I don't know just how easy that data would be, but that perhaps we should be thinking about a chapter on specialty drugs that picks 1 or 2.
Just picks 1 or 2, and when you look at the 25. Costliest, you're gonna find it may, because even in the prescription drug database, there's gonna be specialty drugs, some of them are self-administered. So again, back to like Emerald, it's self-administered, it's a specialty drug. We can go back and look at the data set and say, at this point in time, this is what was paid to pharmacy. This is what manufacturers. The average selling price that they received on the market. So we have this point, we have this point. In between it is all the other cast of characters along the way.
Mr. Chair,
Sure.
if I may, thank you. In response to the professor's comments just now, I would remind the board that if you look at New Hampshire data, which obviously would include New Hampshire public payers, over 50% of the entire prescription drug spend by New Hampshire is specialty drugs. And if you look at the percentage of physician or administered specialty drugs, it's 46%
Of the 50 or
of the entire New Hampshire prescription drug spending.
physician administered outside of the hospital?
Includes both. The reports that you find that is the state mandated report that the consultants for the insurance department produce. And I guess I encourage you to look at them. I mean, we filed them with the board. We're happy to send links again. But, you know, our point, one of our fundamental points is if we're looking at drug spending in New Hampshire, seems to me we probably focus a little more effort on something that might be more than half.
A question. So I'm a bit confused now with respect to whether the data on the specialty drugs are coming off the hospital payments or coming off of prescriptions. You talked about specialty being 50% of the total. Of that 50%, how much are administered in the hospital and how much are administered in the physician offices?
Well, in order to, in response to your question, in order to avoid any intentional or unintentional cost confusion, I would suggest we look at the reports. It's available online, and you'll be able to see exactly what they did. And frankly, I would assume the department would also be happy to talk to you at length about it. And if necessary, you can re-involve Gorman Actuarial to drill down a little bit deeper in terms of the analysis. But it's all there. I would encourage you to use it.
This report's coming from,
This is a state statute requires an annual report done on the cost drivers. It's in the by the insurance department. The report, as I understand it, over the last couple of years, at least, perhaps longer, is prepared by the Gorman Actuarial folks. And it's frankly, I mean, I don't have a doctorate in data, but it's pretty good.
is that something Jason, you can look into?
Yeah,
Insurance
yeah, it's on our website. There's the last 6 years it's been published. I brought 4 or 5 pages that are germane to the on this board here, just like references. It pretty much looked at trends in cost drivers for health insurance premiums and healthcare expenditures, points clearly to some of the main mechanisms cost drivers.
But those costs are on the medical benefit side, not the pharmacy benefit side.
They look at all issues, so they stratify it all.
So they break it apart and how much is
Yeah.
the medical side versus the pharmacy side.
Yeah, they cite that the biggest input for the increase in pharmacy spend is medical specialty drugs.
Okay, so they look at the market, the aggregate, not in the components.
Yeah, I have seen
You should be in the report.
along that line.
Everyone on this board should be aware of that report.
There was a report that I think we discussed. We might have discussed it last time I went back and looked, and it. While it identified the biggest increase was in specialty drugs. Exactly, you know, how that occurred was at least not clear that I got out of the look that I looked at it. I can look at it.
And so,
Yeah,
One
please.
follow-up question. I mean, so I guess this is Shall I ask you or should I ask Don directly?
That's on, please.
So, you know, obviously a lot of in New Hampshire, so many of the communities now are anchored by these hospitals, right? So I don't know how many alternative settings there are for administration of these types of drugs that would need to be in a more medically intensive setting, right? Do you have any specific New Hampshire data that you've not shared with us that we should look at? Because New Hampshire,
On
if that's
site of
true,
care,
yeah, I mean, you talked about, either you or Heidi said that the massive increase based upon drugs administered in, call it just generically healthcare settings, right? And we only, I don't know if we have a lot of alternatives to those healthcare settings, because it seems to me, as I understand the landscape of New Hampshire, that most of those settings are the hospitals that anchor now many of our communities, right? That they just do. That's a fact. So you have any data on that would
I
sort of-
can look and see what the hospital association has. I don't know if we have any specific data on. Like the number of outpatient locations.
Yeah, I mean,
within
whatever I
the
think would be
existing
most
health
specific to New
system.
Hampshire would be helpful, right? If there's
Yeah.
something, you know, national data is national data, but it's different here, as you all know. We've
Right.
been here a long time,
Right,
right?
that's why I think it's important to look at the New Hampshire data, right?
Yeah, I think so. As much as we can, we should.
We can check with the
Yeah.
carriers too, because I mean, I know that the carriers, I mean, this is part of what they're doing to try to manage costs and keep the premiums affordable for businesses and individuals. And so they're always looking at where is the, lower cost sites of care that are still delivering high quality care.
Mhm.
So we can certainly talk to them about that as well.
Thank you.
More. Any more closing comments, you folks? If not, I'll move to,
Appreciate everybody's input.
yeah, thank you very much. Do we motion into adjourn?
So
Okay.
I'll second it.
Undebatable. Thank you, Bill. All right. August 10th, and you'll put this up on the
at 9
website
o'clock.
today, right? October 10th, 9 o'clock. Be on the Warren website, so we have both of those within 2 weeks.
Thank
All
you.
right.
Mr.